performance status of the patient at the moment. The patient is dyspneic, and yet we have to, as pulmonary edema. And the starting dose for pulmonary edema, if you read in most articles, they have done 60 milligrams. So that is the criteria of starting 60 milligrams in this patient. But we saw that probably, there was little response at one point, and then we had to bring in a second diuretic dose. So you have to look into the context of your patient. Is there hypotension that is setting in with your Lasix? Are there electrolyte abnormalities that are coming in? And this is, I think, better if you have a patient in front of you and you can really titrate the doses according to, the outcome that is coming. And we have seen the improvement over time with IV furosemide of 80, and the saturation was really okay. And afterwards, we had to, calm down. If you see this patient, we look at a patient who has chronic heart failure for some time, has developed CKD, maybe because of our low index of suspicion. Their creatinine may not be so abrupt, and Dr. Hajjarah has not pointed that out. But I think, looking at a patient who has acute heart failure, and then at the same time has been having chronic heart failure on the acute heart failure, that is there. We look at, the creatinine of 2.8 milligrams was really high, and that puts you at about stage 4 kidney disease.
Okay.
And you need to put that into context, really work at should I really increase? Because, the nephron mass has really reduced in this patient. So you would be likely to have poor response to lower doses of Lasix, and you must escalate probably this patient to renal doses of Lasix as you go on. I think the cut there is the hyperkalemia, and at the same time creatinine being 2.8. Showing you that there is significant kidney involvement in this patient with heart failure and volume overload. Thank you.
Thank you, Dr. Oriba. I think we can go on to the next presenter. Those with questions, you can continue writing in the chat. We shall pick them and answer them sometime, some other time. So I'm happy to call upon Dr. Linda to come and present.
Yes, thank you very much. So diving right into it, for the previous presenters, thank you very much. Somehow you've mentioned some of the things I'm going to talk about. So just to give a general overview, what happens in the background when a patient presents to you and they have edema. So we know when we say edema, we mean, obviously what you're going to see as a clinician is going to be patient presenting with swelling, but we know in the background what is happening is that we are having fluid building up in the interstitial tissues, and the background could be due to a number of factors, but in the pathophysiology they are either one factor or you're having an interplay among more than one of these factors, and this could be either you're having low oncotic pressures, you either have a high hydrostatic pressures, or your capillaries are being leaky, so fluids are just passing through into the interstitium, or ultimately you're having your lymphatics that are supposed to be draining away this excess fluid being blocked, so eventually this fluid ends up building into your tissues. So when you see this patient either in your OPD, pre-hospital, in your ED, or on the general ward, it is very important for us to know what could be the possible cause, and it is easy for you to group it either, is it generalized edema or is it localized? And for the case where we have generalized edema, we normally think of acute and chronic disorders. So this could be a heart problem, having heart failure, or it could be a patient that either has renal or liver disorders presenting to you with this edema. And then for our localized cases, to think about a possible underlying cause, it could be vesicular, and in vesicular here we are thinking about either the DVT that is deep vein thrombosis, or chronic venous insufficiencies. And then other things that can happen, we see local infections, patients coming in with cellulitis and they have that particular limb or that particular arm swollen. And then other things we see things like angioedema. This is common in patients that are exposed to particular drugs. So for these patients that are non-hypertensive, taking things like ACE inhibitors, and the culprit here could be losartan or captopril, things in that line, it could be predisposing them to this angioedema. And then the other things that we normally see still is the lymphoedema, where we are having our lymphatics locally being blocked. So with that overview, next I'm going to talk about how we assess these patients. And remember, we said that these patients will present to us anywhere. As I mentioned, it could be in a pre-hospital setting. It could be a patient already admitted on your ward. As you're reassessing day 3, day 4, you discover that your patient has edema. So having this background information on the cause is very important. So as we are assessing this patient, it's important for us to use the ABCD approach. Reason being that this presentation, the patient can be either mild, moderate, severe to the point of being life-threatening. So when we begin with our ABCD approach, we are likely to pick up exactly that is going to immediately cause mortality to this patient. So, and here with the A, this is now our airway. So for patients that are having underlying angioedema as the cause, I mentioned particular drugs. So this patient, you assess them and you see that they already have a swollen face, swollen lips, swollen tongue. You know that it's a matter of time before they lose their airway. So this airway is really compromised. It's important for you to either know what to do, and if you're not in a position to do that, know that at this point I need to quickly have the ENT or the anesthesia or the emergency team experts that are able to put in airway tubes to secure this airway. And as we are assessing, when we continue assessing them in their breathing, we want to be able to note their work of breathing. We want to look for particular red flags. Are you able to pick up any wheezing? When you go into auscultate, do you pick any fine crackles? Are you picking any prutic friction rub? Is the air entry good? Is it reduced? Do you have a dull percussion note? And now the dull percussion note is going to be pointing you towards possible fluids in the lungs. And this is already a red flag in its own. And also importantly, record the oxygen saturations of the patient, plus their overall presentation. Are they cyanotic? Because if a patient is drowning in their own fluids, definitely they will be very cyanotic. And our cardiovascular, remember to get your peripheral pulses, document them, get your BP, and importantly, do a good cardiac exam at this point. Observe if we have any engorged neck veins, get their levels, check if we have an hepatojugular reflex. Go ahead and appreciate these heart sounds. Are they present? Do we have a murmur? Do we have any thrill? Do we have our apex beat being displaced? Because all these things are red flags. They are showing you that the cause could either be heart failure or giving you complications with the lungs. So it's important for you to note, because this will definitely guide you on what particular investigations you're going to do, who you need to call in, or where you need to send this particular patient and how they're going to get managed. And then in your D, in assessment, we need to know, is this patient fully conscious? Because as I've mentioned, the patient might be with mild presentation or to the point of being life-threatening. So for you to get the patient's level of consciousness is important. For our patients who have been with us longer on the wards, it's important to know that our GCS is changing, and this will indicate something. So to think of something bigger that has already been missed, and then we go ahead and investigate for it. Importantly, in our exposure, we want to now get to know what are the demarcations of this edema. Is it pitting? Is it non-pitting? Is it bilateral? Is it just a particular part of the body, or it is generalized? And then we want to expose our body, look for any obvious signs of either a rash, which could be pointing us towards anaphylaxis. Check if our abdomen is distended. Is there any ascites? Is there any hepatomegaly? Is there any splenomegaly? Is the patient in pain if they're able to respond to you? Is there tenderness? Is the particular area hot? Because now this is showing you that this could be possible infection causing the presentation of the patient before you. And then important also note if there is any obvious erythema with this patient. So with this initial examination, we're able to identify whatever is life-threatening and then begin the actual intervention, which reflects also the way our team from Lacor presented their case. They were able to show you their particular assessment and whether a particular intervention was needed based on the finding. And then to further add up this examination, we need to get a quick sample history. Remember, I said that sometimes these patients are already with us, so we know some background history, or sometimes a patient is critically ill, they're not in position to talk to you. So where you're able to obtain this history, we want to know the symptomatology. How has this been? Is it acute onset? Is it chronic? And in acute onset, we are looking at things happening within a few hours to a few days, vis-a-vis if it's been a known patient attending a particular clinic, and we know this patient has always had their baseline edema. And important to know is if a patient already has any diagnosed medical condition. Is this a known cardiac patient? Is this a known renal patient? Is it a known liver patient? If it's a kidney patient, then you want to know, are they regular on particular medication? Have they been scheduled for dialysis? That we know in our setting it's a cost. So have they missed their dialysis sessions because they can't afford? Have they missed taking particular medications that it's making them now present like this? And then for things like liver failure, important to note, is this patient a chronic alcoholic? Have they noticed any other associated things like swelling progressively? Is there any jaundice? Is there any easy bruising and then also bleeding without clotting? And then is there any particular change in mentation? Because we know with liver failure, the more the grade worsens, the patient becomes more and more drowsy to the point of being comatose. Then other things to note in the patients that are known heart failure patients, are they having associated difficulty in breathing, exertional dyspnea, PND, and is their level of appetite markedly decreasing? Because all these are important things for you to know if this is a mild presentation or if it's a particular red flag that I could become very anxious and have everyone on board so that I don't worsen this patient's morbidity and mortality. And then also importantly to note is if they've been on particular medications. As we've seen, particular medications can predispose you to the risk factors. And then we know that also injury can make you get edema. And commonly here, if a patient has had long bone fractures, so this could be either a patient in a pre-hospital setting, a patient who is already on the ward, they have been immobilized, so they are having risk factors that are pushing them towards having a DVT that will ultimately push them towards getting a PE. So they'll be presenting the way they are presenting to you. Important to note if there has been any particular surgery performed in this patient, because we know also surgery predisposes these patients to being bedridden. So you finding a patient on your ward having this particular presentation makes you think about a possible underlying cause. And then also another thing that is important to note in these patients that are attending particular clinics, it could be a cancer clinic. If someone has been able to have a record of their daily weights, and on this particular day you see them that their weight is progressively increasing, they're having distress in breathing, yet they are telling you they're not feeding well, then you know that this problem, it's an acute and chronic thing, and then ultimately there are particular complications that we are going to anticipate, as we'll see in Dr. Dan's presentation with emergencies and the kidney disease. So with this quick examination, quick history, then there are particular things that you're thinking you're going to be able to investigate. So we want to normally group our investigations because there are those that you can do bedside to help guide you on particular things you need to do. And also at the back of your mind, know what, how stable is this patient to be able to move to get to a particular place. Always be aware of your facility. What are you able to provide? For those that you can't provide and you know they are critical or you need a particular expert, then you need to plan to refer this patient to that particular place, because we know time is tissue. The more we hold on to these patients in our unit, if we can't do particular things, we are worsening their morbidity. So generally investigations, we can have a CBC being done. We can have, and in the CBC here you're looking for particular signs pointing towards things like an infection. We know that ultimately if a patient has anemia, they can also present with some form of edema. So you're able to tie up your CBCD in relation to the patient that you have. Other things that are important to do is getting a complete panel of your renal function tests. Here, importantly, we want to know our creatinine, we want to know our electrolytes, because we see for these patients that have an underlying cause of renal disorder, we will have our creatinine markedly increasing or worsening. Then when we get electrolytes, because sometimes if these are chronic patients and you're giving them particular diuretics, we commonly get derangements in the electrolytes. So if you don't measure this, patient will have other complications. So it's important for you to measure this, know where the patient is and know what to do in terms of managing the underlying electrolyte imbalance. Then also importantly, if your facility is able to get for you a blood urea nitrogen, also get it. This reflects your kidney, your overall kidney functions. Interpret it in relation to the patient before you. That's in terms of their age and their hydration status. So the more it increases rapidly, then you know that the underlying kidney disease is also really severe. Other things that you can still do is your complete panel still of the liver function tests. And here, importantly, you're looking at the serum albumin levels, because we know when we have cases of either malnutrition or where we have protein losing enteropathies, these patients will ultimately also be predisposed to getting edema. And we know in our management, once they're able to ascertain it for a particular cause, then it makes your management easy. Other things we need to do, getting our urinalysis done. Good enough, this can be done by the bedside. So importantly here, note if you have any proteins in your urine, note if you have any gross hematuria, and also if you're able to check for any microscopic hematuria. So this could be in line with underlying nephrotic syndrome as the cause of your patient presentation. Other things we can do bedside in our particular settings, where we have our portable x-rays, we can do this when the patient is with us, not having to move them because they're very unstable. We can do an ECG for this patient based on what we think the cause is. If we think it's towards heart failure, and because most of the electrolyte imbalances will have particular things showing up on the ECG. So doing a bedside ECG will also be very important. For people who have the skill and the expertise in POCUS, so getting a point of care ultrasound, getting a cardiac echo done on this particular patient will give you a lot of information about this patient. And then other things that we can do based on still what you're thinking. If you think the patient has any risk factors, or from your examination you saw features pointing towards a possible DVT, so you getting a lower limb extremity ultrasonography would be very important. It will help you to know which particular vessels are having venous insufficiency, plus also where you're having possible clots in the veins. So tying up to know exactly where the possible cause is. And then for things that are complications, like you have a DVT complicated by a PE, then if you're able to, and you can get a pulmonary angiogram, go ahead and get that, because it will show you definitively what you need to do to manage this patient if you confirm that the patient has a DVT. And then important to note, remember we said that sometimes these patients are with us. It's not going to be a one-off. You begin particular medications, you need to continuously be monitoring this patient, because we know now, like for diuretics, we are going to begin having changes in their electrolytes. Then we know there is a risk of getting hypotension. So you want to keep monitoring your patient's vitals and also those quick electrolytes that will rapidly change. So with all this at the background, you know where your particular patient lies, the possible underlying cause, then you plan. If in your unit you have all these particular experts, let me say if you have the cardiology team, if you have the internal medicine team, or if you have the intensivists on ground, then you know you're going to consult them earlier on, consult them or refer this patient to their unit. Then in cases where you don't have any of these services within your facility, please remember to consult and then refer there. So for the teams that are going to receive your patient, know that when patients are sick, sometimes they can give us information, but other times they can't. Or by the time they reach a particular expert, a consultant to be reassessed, they could now not be in position to give them extra information. So as you're referring your patients, make sure to have all this information nicely recorded and then relay it to the receiving teams that are able to even plan for you. And sometimes you might have missed out something, but as you're giving the particular findings, the person you're consulting is able to point out particular things to you, and if you're able to either do a quick intervention in your unit, it will be very helpful and it will save your patient. Yes, thank you for listening.
Thanks very much, Dr. Linda. Thanks for the presentation. That was a good one. According to the questions that I've seen in the chat, most of the questions were directed to Dr. Linda's discussion, of which she has answered most of them. Unless there is any other question that Dr. Linda has not talked about, you can bring it out, one or two, before we go to the next presenter. Hello?
Yeah, in the chat.
What I picked in the chat is the cause of edema in adult, cause of pitting edema and non-pitting edema, which Dr. Linda talked about. And then the others, the management of edema, that will come with the other presenters. And also she talked about the weight. Then the one he asked about the passing of urine and passing of the catheter and monitoring the urine output. Dr. Hajjarah was able to answer it. I don't think there is any other question at the moment. If it's there, we can put in the chat as we call in the next presenter. Okay. I don't see any hand. Okay, at the moment, I'm glad to introduce Maria, who is going to take us through the nursing care of patients with edema.
Okay, thank you so much, the moderator. My name is Angut Madalen, and I'm a nurse from Kiruddu National Referral Hospital. I'll take you through the nursing care plan for a patient with edema. Okay, so I've arranged the management in form of nursing diagnosis. Under first nursing diagnosis, we have ineffective breathing pattern, which is related to increased physical exertion, fatigue, anxiety, and obesity. Now, this comes about the limited space in the lungs when the patient is actually breathing in and out. So the lungs are not able to expand well, and this leads to the muscle exhaustion, and where the patient is going to present with, or it's evidenced by a respiratory rate, which can be above 20 breaths per minute. And you'll also be able to note the respiratory sounds like wheezing or crackles. This is where you will use a stethoscope to auscultate. If you check the oxygen saturation, this patient will also present with oxygen saturation of 92 below. And then you'll be able to see that the patient is using the accessory muscles to actually breathe. So in this management, our plan or the goal is that within 45 minutes, we should be able to obtain a normal respiratory range. That should at least be between 12 to 20 breaths per minute. And we also plan to relieve fatigue of this patient, and we also plan to allay the anxiety. And these are the following ways of how we are going to achieve this. These are the interventions and the rationale. One, we will do oxygen therapy. If the oxygen level is below 92%, we are going to administer oxygen therapy to this patient, preferably 15 liters with a non-rebreather mask. We are starting with an elevated level of oxygen liters because we would like to achieve the maximum oxygen production. So we will titrate, we'll be titrating this oxygen flow after 15 minutes of assessment of this patient. And the second thing we shall do in the intervention, we are going to elevate the bed to the level of from 45 to actually 90 degrees. And this is to enable the patient to breathe well. It will enable the patient, it will enable the chest to be opened, and it will improve on the respiratory rate of the patient. Then reassurance. The reassurance, we are managing the anxiety that this patient is having. We'll reassure the patient in order to allay their anxiety and create a good nurse-patient relationship. Another thing is we will open the adjacent windows, and this will be to enable a free air circulation in the room where the patient is admitted. And then we'll also remove the tight clothings and jewelries like necklaces that could actually be very, very, very compressing to the patient's neck or the chest if it's a tight cloth, so that it enables the patient to breathe at will or freely. Evaluation. So within 45 minutes of intervention, we'll be able to evaluate whatever interventions, whatever nursing interventions that we've given to the patient. And in our intervention, we should enable that, we should be able to find out that there is improved respiratory rate of the patient. That is at least within a range of 12 to 20 breaths per minute. And we should also be able to find out that there is improved oxygen saturation. That should be at least above 92 or from 80 to 100% within that range, because the patient may not improve totally within 45 minutes. But after 45 minutes of a nursing intervention, you should be able to see that there is an improvement, and that is when you can make another plan or add more 45 minutes and continue monitoring the patient. In our evaluation too, we'll be able to see that the patient is actually calm, and the patient may verbalize to you that, oh, I'm feeling better, or I'm actually relieved and I feel better when I'm breathing. So that's the evaluation. The second nursing diagnosis to a patient with edema, we have excess fluid volume. And this can be related to the renal dysfunction, as the previous discussants have talked about. It can also be related to the cardiac dysfunction. It can also be related to excessive fluid intake and excessive sodium intake. This is because sodium tries to attract and hold in more fluid in the body. So if a patient who is already having a renal dysfunction or renal impairment takes in a lot of sodium, it will be the component that is attracting or holding this fluid into the tissues instead of being excreted out through the kidney. This second nursing diagnosis is going to be evidenced by weight gain over the short period of time. One of our presenters talked about detailed history taking. So if you take a detailed history, you'll be able to find out that the patient has overgained weight within a very short period of time, like maybe 2 weeks or 3 weeks. And then there will also be body swelling. Looking at the patient clinically, the patient will actually be presenting with body swelling. It can be generalized or only the limbs or the facial swelling. Yeah. And then the next evidence is going to be intake that exceeds the output. And this you will only know that by noting or monitoring the fluid intake using a fluid balance chart. You will be able to know that if you administer a liter of fluid, at the end of the day or after 3 hours, the intake that you've given is exceeding the output. That means the patient will have a diminished urine output. Is that we would like to, within 72 hours of nursing intervention, we would like to eliminate the excess fluid and obtain at least 60% of a normal weight range. And we will achieve this by the following intervention and the rationale. 1, we shall administer prescribed medications. The prescribed medications may be diuretics like furosemide. This will be according to the doctor's examination. And another thing we shall do is to maintain a strict fluid intake as ordered. Depending on the patient's condition or the severity of the condition, a doctor will be able to limit the amount of fluid that the patient should actually take or receive in a day. So we shall maintain this strict using a fluid balance chart and having a urinary catheter in situ. The next is monitoring fluid input and output. I think I mentioned already this partially, that we will have a strict fluid balance chart and having a urinary catheter in situ. This will be able to tell us the amount of fluid that we are giving, and we'll be able to measure the output through the urinary bag, a calibrated urinary bag. So that means before you empty the urinary bag, you should be able to note the amount of urine that has been collected in the urinary bag and the time range that you have achieved that, so that you compare with the amount of fluid that you've given. We shall also restrict low sodium intake by the patient. I said earlier on that the sodium intake retains a lot of fluid, because water can be attracted to salt because it's trying to balance a lot of maybe sodium that the patient has taken. So in this case, we are going to maintain or lower the sodium intake. And the last intervention under that is daily weighing. So the daily weighing, we shall do it every morning or at any specific time that you have chosen, but we keep the time for the daily basis, or to achieve the 72 hours that we have put, so that we'll be able to note the difference. And this will tell us that if the nursing interventions that we're putting in place is actually giving us a better result, or do we need to shift or increase on the time of the goal or the plan that we have put. We shall carry out evaluation of this within 72 hours, that is a post-intervention, and we should be able to note that there is actually an improved urine output, comparing with what we have been noting in the fluid balance chart. And there will also be at least some reduction in the patient's weight. It may not be totally, as you look at the nursing care plan time, we are only having 72 hours for the nursing intervention. So this, we may not achieve the right range of the patient's weight, but this will give us a flow that, the nursing interventions that we are carrying out, actually giving us a hours. And the last nursing diagnosis that we have here is a potential nursing diagnosis, that is the risk for impaired skin integrity. The risk for impaired skin integrity is related to decreased tissue perfusion, altered skin turgor, and extracellular fluid volume. So we know this is a risk nursing diagnosis. It has not yet taken place, but we need to prevent it. So this is a preventative intervention. One, we shall keep the skin dry and clean. We'll use a Vaseline to actually keep the and not dry, rocky. And then we will also apply a compression stockings. I think most nurses know the compression stockings. This will help to keep in the tissue intact and not enlarge more, which can predispose it to any danger or any prick with the sharp objects. So this is the general nursing care. As you've seen, I have only given 3 nursing diagnoses. Two were the actual nursing diagnosis, and one was the potential nursing diagnosis. But this is the general nursing care that you will have to continue with the management of a patient with edema. So one is most important is that reassurance. As a nurse, you need to continue reassuring this patient and their relatives to allay their anxiety and to let the patient feel comfortable and have hope that they will get better. Another thing is a vital observation. The vital observation you can carry out is a blood pressure. You can carry out pulse. You can do respiration rate. You can carry out oxygen saturation, and you can also note the temperature. This you will use an observation chart and make sure you carry out your vital observation and you chart it very well and you sign against it. In nursing, we say anything that you've done which is not documented is actually not done. The second general nursing intervention, we have 2-hourly turning. We are going to turn this patient every after 2 hours. It's because the patient is at a risk of getting a pressure sores. The patient is edematous, may be able to turn by himself or not. So if the patient is not in position to turn by themselves, we need to turn them every after 2 hours in order to minimize the risk of pressure sores. And feeding, the patient needs to eat. It's not all about giving drugs and 2-hourly turning. So we need to feed the patient, but considering what I noted above of low sodium intake, strict fluid management. Another thing is about hygiene. Nursing cannot go without hygiene. We will have to carry out things like oral care of the patient, caring for the bed linen, caring for the bowel, that is offering bed pans to the patient, cleaning the linen, doing bed bath. Okay, these are some of the nursing hygiene that we'll have to carry out. The next thing is use of bed appliances like pillows, airing, hot water bottles, cardiac tables to ensure that the patient is comfortable. We will use pillow especially if we position the patient in a sitting position, and the airing actually helps to release pressure. So you'll have the patient to be seated on the airing, and then hot water bottles to provide warmth to the patient. And the cardiac table will help the patient to lean on it if they are not comfortable sitting, or actually make them use a pillow on top of the cardiac table, and they'll be able to rest their shoulders. All this can be done in order to help the patient feel or be comfortable. The second last thing is the care of the pressure areas and treatment of the pressure sores. We have some of the pressure areas like the scapula, like the hips, the heels, okay, those are in between the breast if that's a female patient, and in between the buttocks or any skin fold. We need to care for these pressure areas, and we care for it by cleaning these folds or concentrating in this area to make them clean and dry and not sweats accumulating there or any kind of fluid that can easily irritate the skin and leads it to rupture. So if the pressure sores has already taken place, we will also do the pressure sore treatment. The last general nursing intervention for patients with edema is physiotherapy. The physiotherapy part of it is actually the exercise. You'll do it in 2 ways. One can be active and one is passive. So the passive exercise is by you, the nurse, or me, the nurse, to enable the patient to control actually the muscle rigidity and make the patient remain flexible even though they are really very sick on the bed. So with the passive exercise, the nurse helps the patient lifting the legs, lifting the arms, massaging, and then the active part of it, active physiotherapy, here is when the patient is now able to walk or sit out of bed. So you help the patient rotate around their beds, and maybe in 3 days or 4 days, you can actually help the patient with maybe a wheelchair or holding their hands, and you take them a walk around within the wards, and later if you see they are really stable, you can take them out of the unit to sunbathe and get fresh air. So that has been the presentation, and the reference is from the NANDA, that is 2021 to 2023, 12th edition. Thank you so much for listening.
Thanks very much, Maria, for that good nursing presentation.
You're welcome.
I'm really glad, and I hope if we followed the nursing care that she has really presented, you cannot miss out on any management on this patient. It has been a very good one. Thanks very much. Now, before the next presenter, I see most of the questions that are in the chat are about management, and our next presenter, Dr. Oriba, is going to talk about management. And I hope all these questions will be answered during his presentation. So allow me to call in Dr. Oriba to come in for his presentation. Thank you. Dr. Oriba?
Thank you very much, team. Thank you very much. Today seems to be a Lacor day to present. And without wasting time, I think I'm going to discuss management of acute kidney injury. We are going to look at the emergencies that are there in terms of, patients who present with acute kidney injury. We selected this because most of these patients would also present with edema in one way or the other. So looking at this, we think okay, so acute kidney injury is defined by abrupt onset of usually reversible decline in glomerular filtration rate. And normally this results in increase in your blood urea nitrogen, creatinine, and of course, other metabolites, which are the waste products that comes as a result of kidney elimination. Now, if urine output is also diminished, these patients are likely going to be oedematous, meaning they are retaining a lot of their fluid, and they would present with complications of volume overload, whether it being heart failure, pulmonary edema, and so many others. So AKI may cause sudden death in these patients, life-threatening biochemical disturbances as a medical emergencies. We know all the complications of uremia and hyperkalemia, which can really fasten, the process of death. Going forward, the epidemiology of acute kidney injury, we have very little data in this country regards to kidney injury. However, a lot of work has been done in chronic kidney care under Professor Kale Subula, who is still continuing to do that. But here you see that in the ICU, about 20% of all admissions would, have complications of acute kidney injury. And of this, 25% of those with acute kidney injury would require renal replacement therapy, and 5%, 5% of this would present in general hospital population. So even still, acute kidney injury should be taken in context that is very common in our setting, and we need to really have high suspicion for it in terms of diagnosis. Now, when you talk about acute kidney injury, you want to look at the etiologies. What are the things which are likely going to give you acute kidney injury? In hospital stay, the most common mechanism would be a pre-renal mechanism before anything which affects you before the kidneys. And of course, pathologies within the kidney, and then pathologies in terms of the elimination structures of the kidneys, like the prostate, the urethra getting blocked. So in the pre-renal, we see clearly that hypovolemia of any cause, whether it being from heart failure, from patients with liver failure, and of course, patients who have been on NSAIDs, overdose, ACI and cyclosporin, they are likely going to, present with a pre-renal AKI. And of course, sepsis is also on the pre-renal aspect, much as it has, a multi-etiological aspect of both intrinsic and pre-renal in terms of its mechanism of kidney injury. Now, under the intrinsic, you have acute glomerulonephritis, tubules and interstitium, and of course, kidney ischemia from any other cause. Post-renal causes are likely going to cause you bladder outlet obstruction, whether it being you have a stone at the trigone of the bladder, and then you have obstruction of any sort. So this diagram simplifies for you where the mechanism of your kidney injury is coming from. So looking at, before you go directly into the management of, emergencies in kidney disease, you need to know the classification of, acute kidney injury. There has been a lot of development right from the rifle classification, from the Akin, and then now we are using the KDIGO classification, which is based on the 2012 meeting, and classifies acute kidney injury in 3 stages: stage 1, stage 2, and stage 3, where stage 3 worsening stages requires higher interventions. Now, stage 1 is when you have either an increase of greater than 26.5 micromole or 0.3 milligrams per deciliter of creatinine. And also this in resource limited setting covers us, especially if you can't do creatinine immediately, you can go ahead and look at urine output criteria of less than 0.5 mils per kilogram per hour for the first 6 to 12 hours. And so this diagram that you see really summarizes for you where your patient falls and how should you manage this patient. Now, patients who are in stage 3, they can either present with anuric AKI or they may present with the AKI and they are passing urine. So, not all patients with AKI are likely going to present for you with anuria. Those who are passing urine and they still have AKI means their kidneys are functioning suboptimally and is not eliminating the metabolites and the toxins that is supposed to eliminate from the body. So that diagram summarizes for us the diagnosis. The presentation of acute kidney injury is multi-systemic. When you look at the cardiovascular system, you're looking at presence of physical examination. Also detected on ECG pericardial effusion. They're also likely going to get myocardial infarction and then pulmonary embolism. Under metabolic, these are the things that you have to look at. Hyponatremia, hyperkalemia is the major thing that we put high on the table. Acidosis, hypocalcemia. We are going to look at a very critical case that we managed here at Lacor, a patient with both hyperkalemia and hypocalcemia presenting similarly on ECG. So neurological, when you tell the patients to put their hands like this and you tell them to flap, they will have this kind of flap. So tells you that,
Yes, doctor. Dr. Oriba, we can't hear you. Hello? Dr. Oriba, we can't hear you.
There is a lot of, uremia goes into delirium of the uremia that they are. He's back.
Yeah. You are muted. Hello? Doctor, unmute yourself. It's off. Let's be patient. He'll be back. I think he has a network problem.
I cannot share my screen.
You can share now.
So if I can't share my screen, then I think we go straight to, following up still on the presentation. You have to do.
Excuse me, Dr. Riba. You have been given the mandate to share. You can share your screen.
I think the host has muted all of us from there.
You are not muted, Dr. Riva. You share your screen.
Have we been unmuted already?
Co-host, so you have the right to share your screen. You have been made a co-host, so you can share your screen.
Hello. I think, yes, I think we have been unmuted by the host. Okay.
Okay, they are going to share for you. Yes, Dr. Riva. The presentation has been shared. Can you see it?
Okay, I think you can go to the next slide.
Okay.
So in the pre-renal azotemia, you look at the urinalysis in this patient. In the urinalysis, you look at the urine electrolytes, which will help you also in the etiology. So you have to evaluate the need for, urgent renal replacement therapy in these patients, because it's likely going to help you save the life of this patient much more earlier. So correct pre-renal azotemia, correct electrolytes abnormalities that you find. Next slide, please. Okay, so in the urgent evaluation and management, you have to systemically evaluate these patients for immediate threats and complications. And you assess the severity of the AKI basing on the KDIGO classification, identify the cause, and then you treat appropriately. So the KDIGO classification from stage 1 mild to stage 3, which is severe. And we know that the complications associated with AKI are more severe, are more in the severe form, and they are life-threatening with higher stages of the AKI, meaning from moderate to severe. Can go to the next slide. So in the management of AKI, you look at the types. Pre-renal, you want to use the STOP algorithm. In the STOP, you look at, you have to treat, STOP denotes early, sepsis and volume correction. S is for sepsis. Withdrawal of toxins, whether it being medications that the patient is on, and you have to really stop that medication. And at the same time, withdrawal, excluding obstruction using ultrasound scan. And at the same time, seeking renal parenchymal disease through a urine dipstick. And then, of course, the clear majority of AKIs are due to pre-renal cause in our hospital. So you have to really adequately resuscitate this patient, monitor them, and then correct the pre-renal cause to prevent progression. We can go to the next slide. Okay, so in the immediate management, fluid resuscitation to correct pre-renal factors, hypovolemia or sepsis-induced vasodilatory hypovolemia is important. As the nursing team has also mentioned, monitoring of urine output using standardized fluid balance chart and daily weight to assess volume status of this patient is also important. You have to look at the patient treatment chart, all their medications that they are taking, and you have to review their risk for progression to, higher degrees of AKI by stopping nephrotoxic medications and non-essential medications that this patient doesn't require. And those other medications that the patient requires, do dose adjustment of the drugs according to renal function as required to avoid accumulation of the toxic elements because the kidney is not functioning optimally. We can go to the next slide, please. Okay. In the immediate management, still on the continuation, urinary catheter is required if clostering is, but if the patient give you their urine, can be able to collect their urine diligently, please, you don't need to put urinary catheter. Use appropriate antibiotics for suspected sepsis, antibiotics which doesn't compromise your kidney functions, and then urgent management of hyperkalemia on guideline basis. Okay. So we look at the complications of acute kidney injury that might require emergency kidney replacement therapy. When patients present with pulmonary edema and is not responding to diuretic management, okay, they are in volume overload, you really need to think of, starting them on kidney replacement therapy. And there are two forms majorly. We are going to look at it. Hyperkalemia greater than 6.5 is an emergency in an acute kidney injury, though this can be tolerable in patients with chronic kidney disease. And you look at the signs and symptoms of hyperkalemia, cardiac conduction abnormalities, patient presenting with muscle weakness, hyperkalemia of greater than 5.5 if you have ongoing tissue breakdown, assuming someone is brought from, in an accident, an emergency, and there is ongoing rhabdomyolysis, the person has shattered all the thigh, and the potassium levels is greater than 5.5. That patient is an emergency. And of course, you have to stop ongoing potassium absorption by giving medication which binds potassium that the patient can take orally. We have so many on the market, things like the Lacor and other potassium binders which are there. Signs of uremia, such as pericarditis or otherwise unexplained decline in mental status. And of course, under uremia, you look at uremic pericarditis and uremic encephalopathy, and sometimes bleeding diathesis. Those are the absolute, indications that you should probably start kidney replacement therapy. Severe metabolic acidosis, whereby your pH is less than 7.1 and you have hypovolemia, unless acidosis can be corrected by quickly correcting the underlying cause, especially in patients with diabetic ketoacidosis. This patient would require kidney replacement therapy. And in acute poisoning, okay, dialyzable toxins, you have to consider, probably kidney replacement therapy. Can go on the next. Okay, so this ECG that you see, the first one is an impending sine wave pattern, whereby you have broad-based bizarre QRS complexes with absent P waves. There are tall T waves, and this patient is having severe hyperkalemia. From our ICU admission and needed to quickly reverse the potassium level. I think the potassium here was 7.9. And these are typical things that you see with hyperkalemia. The second one, you have tall T waves that you can see there, and a prolonged QT interval, prolonged sinus pause with other premature ventricular contraction. This patient had hyperkalemia of 8, and then at the same time had concomitant hypocalcemia. So all these electrolyte abnormalities can be identified on ECG. I think we can go to the next. Both patients survived. Can go to the next. Okay, so we look at ECG changes in patients with hyperkalemia. We have, the way I've put it there is that we are looking at lead V3. You are seeing there tall tented P waves, okay? The effects of progressive hyperkalemia. This is if you are at the emergency department and you have ordered ECG, you look at the tall tented P waves together with normal sinus rhythm. The sinus rhythm means your P wave is before every QRS complex. And normally this is true in lead 1, lead 2, lead 3, and AVF. So if you have that, then you are dealing with a sinus rhythm. Then when you go to the second ECG wave, the serum potassium was 8.9 and not the tall peak T waves. And now the T waves are eating up your P waves. You can barely see any P wave there. When you see this patient is impeding cardiac arrest from conversion to sinus rhythm, and you really need to work on them very fast in terms of renal replacement, urgent management of hyperkalemia that we are going to see. And then, of course, serum potassium greater than 8.9 milliequimoles, and you note the classic sine wave pattern with absent P wave, marked prolongation of QRS complexes, and peak T waves. This, if you don't start them immediately, probably you are losing the golden time in the management of these patients. We can go to the next. So these ECG features are very important to master them in the emergency department. So this algorithm, I think we can adopt it, ICU management of hyperkalemia. It divides for you into three cases, three. The red one tells you cell membrane stabilization. The cell membrane stabilization is basically achieved by giving calcium gluconate, which we give sometimes 10 mils of the 10%, and you can repeat that dose, and you monitor the patient equally, because potassium is really important in the cardiac myocyte functioning. Secondly, intracellular potassium shift. You have to shift the potassium inside the cells from the extracellular compartment. So this entails that am I still being heard? This entails that you give either nebulization with salbutamol, and then at the same time you can also give insulin. Insulin is very important, and as you give insulin dextrose solution, and then at the same time you can give increased potassium excretion using potassium binders, which we have many in the market, less K, and then potassium other brands which are there. You can give the patient via NG tube, and at the same time you can also give diuretics, loop diuretics, if there are no contraindications, to make sure that you increase binding of potassium in these patients and its excretion. We can go to the next slide. I think this will be seen later. Okay, so again, in the first line treatment of hyperkalemia, to summarize that diagram, we have put it, the first one, you see cell membrane stabilization, hyperkalemia with ECG changes or modification. First line therapy is cardiomyocyte stabilization using calcium salts or hypertonic sodium chloride. You can use that. Of course, it's under study still, but it has proven benefits. Second line therapy is to transfer the potassium from extracellular to intracellular. You can achieve that by using insulin glucose and then IV or nebulize that's IV route, and then nebulize beta-2 agonist. We know so many examples of those. And then you can use sodium bicarbonate in case there is metabolic acidosis and the patient is hypovolemic, depending on the comorbidities and the requirement for sodium bicarbonate, because it has a very narrow therapeutic range. So in the insulin glucose, recommended in first line as in the treatment of severe hyperkalemia. The half-life of insulin in this patient is going to be 4 to 6 hours. So if you have driven the potassium inside the cells, make sure that you again repeat that procedure 4 to 6 hours to maintain the potassium inside that cell. Otherwise, it can still come out and the patient can still go into cardiac arrest. That is atropine in that case. So increasing potassium excretion, it decreases the total potassium pool and helps, of course, to maintain the hemodynamic stability of this patient. Loop diuretics like furosemide and then potassium binders helps a lot at this stage. So those three mechanisms are very important in management of hyperkalemia. Can go to the next slide. Okay, so in renal replacement therapy, we have two types of renal replacement therapy: peritoneal dialysis, where you have prepared a peritoneal dialysate, you infuse it inside the abdomen, and you use the peritoneal fluid as a natural barrier, filtration membrane. And then afterwards, after some hours, you remove the dialysate from inside the abdomen using an external drain. And this also helps a lot in the acute management of acute kidney injury. We have already, studies and very good outcomes from it. Of course, it has its caveats in certain patients. Now, in hemodialysis, the one you see on the right, this patient is undergoing hemodialysis through a venous access, which has been put. Emergency hemodialysis is also very important. It helps in faster stabilization of the patient if your conventional medical therapy has failed to achieve. And of course, in patients who are septic and in other conditions, again, the mode of renal replacement therapy will vary, where you would require more advanced method of kidney replacement therapy. That is just a diagrammatic presentation. We can go to the next one. Okay, so in the management of AKI, if we go back, if intrinsic renal disease is not suspected and prerenal factors, which is the most common cause of renal injury in our hospital, is corrected, the usual cause is normally that the kidney function will improve. And of course, the emphasis then shifts to maintaining that appropriate fluid balance. You have already managed the emergencies and the kidney is recovering. Make sure that the patient is appropriately managed on the fluid balance chart, monitoring electrolytes and surveillance for any complications that may arise. Have a fluid balance chart, weigh the patient daily monitoring of electrolytes, including bicarbonates. Of course, this is a very big challenge in our setting, and review the needs for keeping the central lines in this patient if they have been very sick and they still have central lines, because can be cause of infection in them. Dialysis catheters or urinary catheters also has to be reviewed if they really need to be in place, since they can increase the risk of infections in this patient. I think we can go to the next slide. So in the phases of acute kidney injury, in the prerenal phase, you have the inflammation phase, extension phase, where they can still go into chronic kidney disease, and then the maintenance phase. And then, of course, by day 6, you are seeing recovery of these patients. This has been adapted from Kidney Disease International, and I think we can get it. We can go to the next slide. So thank you very much for listening. Any questions? I think we will be welcomed.
Okay, thanks very much, Dr. Oriba, for that wonderful presentation. There are some questions that I was able to see in the chat. However, according to the presenters, I see most of the questions were answered about the management of the patient with edema. The other question that was not answered, this goes to Dr. Oriba, is what is pseudo hypokalemia and how is it ruled out and how is it managed? What is pseudo hypokalemia? How is it ruled out and how is it managed? And then another question is about
pseudo-hyperkalemia is not really a true hyperkalemia in these patients. It normally comes because of lab artifacts. As you're collecting your samples and you forcefully eject the blood through a narrow syringe into the vagina. That is one. Secondly, if you have, if the time from blood sample, the time you have taken from sampling the blood up to the time that you take from analyzing the blood in the laboratory is long, then you can get pseudo-hyperkalemia, which really you don't need to manage. Pseudo-hyperkalemia is not really so much, and it normally may not give you ECG changes. Just that, the blood has taken time. It's not a true hyperkalemia. The blood has taken time to be analyzed and has undergone some hemolysis. Thank you.
Thank you, Dr. Oriba, for that wonderful answering. I request the participants that those who have questions, you can raise up your hands as I read some of the questions in the chat. Those also have questions, you can raise up your hands and we answer them. Then also this goes to Dr. Oriba. Some participant is asking about the fluid management, the immediate fluid management of a patient with oedema in shock. Hello?
That is a very difficult question. I think fluid management in a patient with edema and is in shock. I think still you go back to the basics of this patient. The patient is in shock. The fluid, the edema that you see there is a third space. So you need to look at, is my patient passing urine? If your patient is probably not passing urine, you need to work on to, solving the urine problem by removing the fluid, either by, if the patient is retaining a lot of fluid and you can give them, renal replacement therapy at that point is very important because the patient is volume overloaded, is in shock, and then at the same time is oedematous. You cannot give Lasix to that patient. That patient needs, and of course, up to date has two absolute indications of dialysis, where you have overloading diabetic, of course, who are in shock. That's a different aspect. And the second one is hyperkalemia. I think that patient is very renal replacement to remove the fluids. And as you are removing the fluids, you are supporting the hemodynamics of this patient with medications, and at the same time, you are removing the fluid. So I think the patient is very sick and needs other modalities.
Yeah, thank you.
Yeah.
Yes, for that. I'm not seeing any hand in the class. So there's another question for Dr. Oriba. Yes, Dr. Oriba, are you on?
Yes, I'm on.
One of the participants is asking, how do you manage hyperkalemia at the same time hypercalcemia?
So, in the hyperkalemia, we have seen that you need to stabilize the cardiomyocyte by administering calcium gluconate. And of course, if you have hyperkalemia, you start by managing the patient with a calcium gluconate. And if the patient has concomitant hypocalcemia, then you have to give them calcium gluconate. But if they have hypercalcemia, then that is a challenge. You don't go on the route of stabilizing the cardiomyocyte. You go to the first line of treatment of severe hyperkalemia. And in that case, you have to institute a combination of rapidly acting insulin with the dextrose in that patient to shift the potassium. And if that fails and the patient is not urinating, is still worsening with the hyperkalemia, then that person still requires renal replacement therapy.
Thank you. Orit, Daniel, please ask your question, unmute and ask your question.
Okay, thank you very much, ECHO team, Daniel Oriba, for your presentation. It was really so informative. For my just about sharing experience, because most of us, and there comes a time when a patient comes with edema and needs albumin. So what happens in some of our country setting, we have been giving them egg white. I don't know, in Lacor, does that come across your mind, or if you guys have a lot of albumin that you have at disposal to give patients? What's your take about egg white to replace albumin, especially in patients with kidney disease, liver failure? And even in kidney disease, we all know that Lasix furosemide rather is carried by albumin. So if I have a low albumin level, then even if I'm administering big doses of Lasix, it's not being carried to where it's supposed to act. So I'm just wondering, in Lacor, are there moments when you guys lack albumin and you're forced to give a patient, you're forced to tell a patient, eat egg white, or you always have albumin at your plate? Thank you, and over, Dr. Oriba.
Should I answer?
Thank you, and over.
Should I go ahead?
Yes, please.
Okay, Dr. Reed, thank you. I have to admit, Dr. Reed is my senior and he supervised me as an SHO. He's asking me very political questions that he would have answered by himself. But let me go ahead and answer it. Dr. Reed, albumin is very important in patients with acute kidney injury. Especially this has been demonstrated in hepatorenal syndrome. If you have low albumin, administration of albumin in these patients actually improve their AKI and reverted, progression of an acute kidney injury. So yes, if their albumin is low and you think the edema is because of the low oncotic pressure, administration of albumin is likely going to help them. I've also forgotten one aspect. There is recent information that is coming on, and it has already been proven, administration of paracetamol in patients with acute kidney injury. Please, guys, go and read about it. Maybe this is something that we can help. In our patients who have acute kidney injury, if they don't have concomitant liver injury, give them paracetamol as the analgesia of choice. And, it's likely going to help you in reducing the kidney injury in this patient. Still, the mechanism is not yet very clear, but this has been proven from many other case reports, retrospective studies, and observation studies across the world. Thank you. And albumin is very expensive. It's not readily available. Dr. Reed knows this. The cost of one vial of albumin is 275,000 Ugandan shillings. So this is not a medication which is easily available in Lacor Hospital. But once the patient requires them, we have ordered them from Kampala. And some of them have survived, and those who are in the other aspects who also did not survive. Thank you.
Okay. Thank you, Dr. Riva. As we continue to ask him questions, the post-test is on. You can go ahead and answer those questions. The post-test is on. You can go on to answer those questions as we ask questions. If you still have any other questions or something is not clear according to the discussion of today, please ask. We are here to answer you, to give the answers. Thank you. Yes, Seka, you can unmute and ask your question. Seka Martin.
Thank you so much, the moderators and the presenters for that well elaborate presentation. Maybe to back on that was, I would like Dr. Oriba the use of sodium glucose transporter 2 inhibitors in heart failure. 2, at what stage I bring my beta blockers to control the rate, like for that case presented. 3, let him comment on the use of mineralocorticoid receptor blockers, like spinal cord, and their use in that, and why, like, it was maybe not used in such a patient. Thank you so much.
Over to you, Dr. Riva. Yes,
Let me use, I think I've lost my connection. So the first question is the use of SGLT2 inhibitors. SGLT2 inhibitors at the moment in patients with a stage 4 heart failure, stage 3 and stage 4 heart failure, whether it being with reduced ejection fraction and preserved ejection fraction, has been proven to show benefit in patients with heart failure. So there is no contraindication in use of SGLT2 in patients who have heart failure with indications. And I think the other previous patient that we presented had the indications of SGLT2 inhibitors, but a single tablet costs 9,000 shillings. And you have to take it for a very long duration of time. However, in patients who have concomitant kidney disease, like in this patient, yeah, that was really indicated. It helps prevent the progression of the kidney disease, helps improve also your HB, according to the recent studies that have been shown. So the SGLT2 seems to be a wonder drug, and we think very soon it may even be used for treatment of malaria. That's what other people are saying, because I mean, the drug is treating almost everything. So SGLT2 is indicated in this patient. Secondly, the use of beta blockers. Beta blockers, you have to be very careful. In patients with heart failure with reduced ejection fraction and they are hypotensive, I mean, they are hypotensive, the indication of beta blockers may not be immediate in patients who have been admitted in the hospital. But yes, it can be a preferred drug of choice when you're discharging them. But when you want to give them beta blockers, I mean, there are some other drugs, if their heart rate is really, really so high, use of low dose beta blockers, low doses to control the heart rate in that case, and give more time for ventricular filling would be very important. And then at the same time, drugs like ivabradine could also come into play at that point. But I don't want to go into the details of cardiology because that is not my area. And there are people who would say he's telling us lies. And I don't want to be labeled already. And the last one is spironolactone. Spironolactone is the side effect of potassium sparing diuretic is spironolactone is because it's potassium sparing, and you have to be very careful if your patient is not passing urine very well and their potassium is borderline. Normally, the requirement is that you shouldn't start those medications if the potassium is 5.4. And in this patient who was having issues and potassium is already 5.2, and we are not having adequate monitoring, I think I would be very much reserved. But of course, as you see, spironolactone or these medications are indicated in patients with stage 3 and stage 4 New York Heart Association heart failure. So it's still indicated, but again, you look at the biochemical aspects of the patient and you want to balance everything. And that is how you can just, go on and manage this patient. But SGLT2 is still a wonder drug and can be used in very, very many cases. Thank you very much.
Any other question? As we ask question, please we have the first test which is there. Please let's answer those questions. It seems the questions are over. Those that were put in chat, most of them were answered by the discussants. Unless there's anyone with any other question. Let's do the post test. There's some.
Dear moderator. Moderator.
Yes, please.
I got to ask some question here. It's in the group, but then Doctor never tackled it.
Yes, you can ask, please.
It is, how would you approach the ICU patient with fluid overload, with the congestive cardiac failure, kidney failure, but has smaller hyperglycemia?
Okay.
Yes.
I think that goes to Dr. Oriba.
Can we repeat it, especially the last one? I think if I've gotten him right, we're having a patient with fluid overload and is in heart failure and is having one of the complications of diabetes, which is hyperosmolar states. That is a very difficult question. And I think you still again have to go back to the basics of the management of a patient who is in heart failure, because hyperosmolar state would require you to start this patient on high volume of fluids. But of course, you are again having a patient with heart failure. Again, you look at the patient in terms of the hyperosmolar state. Are they unconscious? Are they having features of cerebral edema? The absence of cerebral edema in that patient is going to make sure that you can give them some fluids while you're monitoring the heart. And then at the same time, they're in heart failure, so you have to give them medications to make sure that you sustain the heart which is already failing. So again, you balance up. That patient is having high glucose, which is not utilized by the body. Administration of insulin is going to be important, and you have to adequately diurese that patient, at least to pass the urine to help you decongest the heart, while also you are correcting the hyperosmolar state. If the patient is very sick, then you have to go ahead and seek critical care intervention. The patient that you're talking about needs to be in ICU and would require multidisciplinary management of endocrinologists, cardiologists, and at the same time, critical care specialists to manage that patient very well. So I think you will have to go back again to the basics. What is more likely going to kill the patient? Is it the hyperosmolar state? Is it the heart failure? Again, you stage the heart failure. Is it stage 1, stage 2, stage 3, stage 4? That is likely going to help you, but otherwise, that is a very difficult patient that you're posing. And yeah, they do exist, because patients with diabetes, one of the complications of diabetes is heart failure, and in the long run, they get cardiovascular compromise. So that is a patient that can present to you, but would really be very sick. And again, you have to follow the algorithm and guidelines to manage that patient with multidisciplinary team. Thank you.
Thank you, Dr. Oriba, for that. The results for the test have been displayed. There you can check. And then please, we are ending the session, but please register. The link is there in the chat for registration. Please make sure that you register. We are ending this session, and we are going to have our closing remarks from Dr. Omo Joseph.
Right, thank you so much. Thank you, moderator, and thank you, the experts. It's been an engaging discussion. We've learned a lot, and we've understood some of the things we should do in our resource-limited setting, but also we should be able to recognize the contributing factors and be able to act so that we improve early detection of and screening of kidney disease in our population. What we need to do going forward is that we let's keep learning, let's keep sharing experiences. This is a platform that we have every other Friday, so we'll skip the next Friday, but the following Friday we shall have a discussion where we'll learn again we're grateful that you've been with us and you've been engaged with us. And we thank specifically our presenters, our panelists, but also you, the participants, for keeping in and keeping us busy, keeping you entertained rather than. Yes, thank you so much. We pledge to be here together with you. We keep sharing our experiences, and we meet again next Friday. Over.
Okay. Yes, thanks very much, Dr. Umu, for that closing remarks. Our kind request of participants to put on your videos so that you can take a screenshot for accountability purposes. You know the things.
Yes, a special gratitude to Lacor Hospital, St. Mary's Hospital, Lacor. We thank you for joining in a group. We saw the participation was in a hub, and we really appreciate this. Going forward, we encourage every station, every hospital to have their colleagues join, and we learn together. We share experiences, but we also learn from our experts that are limited. Yes, and I'm hearing from George Kizito, a lawyer, he also saying even Kiruddu, we appreciate you. So members, kindly put on that video. We take a picture with you. Put the video on. Let's see your nice face.
Presentation slide is going to be shared.
So the links to this session are usually available on all social media platforms, including our YouTube page, but also you could, most of the hospitals have these links. So we encourage, especially the React mentors, and also the team members, if you have the link, kind of share with the colleagues, share with any platform that is available so that people are able to access. Join and learn and share mostly the experiences. We've had discussions from Dr. Reed guiding us and especially following up on his SHO that he taught. Thank you once again.
Thanks very much, participants. We have come to the end of our session today. Thanks for participating. Come again.
Thank you.
Thank you too.
And also for inviting more friends, more people to come in for this.
Thank you too. Bye-bye.
Important for our management of our patients.
How can I register?